Thank you, Sadia. Thank you so much. So now, Bismillahir Rahmanir Rahim. We are going to start with the name of the Allah and with the few verses of the Holy Quran. Bismillahir Rahmanir Rahim. Qul huwallahu ahad, Allahu samad. Lam yalid wa lam yulad wa lam yakul lahu kufuwan ahad. Sadaqallahul Azim. So, on behalf of Society of Obstetrician and Gynecologists of Pakistan, I welcome Professor Arulkumar for being here today with us today. He is going to speak on very important topic, migration from partograph to labor care guide. As all of we know that labor care guide is a next generation partograph which is based on the recent latest eh, recommendation of the WHO on intrapartum care into practice. Its aim to is to improve the every woman's experience about childbirth and the help the women of the for the uh, well-being of the women and their babies. So it is a, as we all know, in our developing countries, over one third of the maternal deaths and half of the stillbirths and quarter of the neonatal deaths occur as a result of the complications of the pregnancy and childbirth. And these deaths are preventable. Knowing timely intervention, when to wait, and when to take action. So I think this is very important for all of us. This labor care guide is a, I think, old, this is the replacement of the old traditional WHO partogram. In this guide, we will learn how to monitor the labor chart and fetal monitoring, maternal monitoring, and especially the respectful maternity care. It starts from the first stage of the active phase of the first stage to the end of the second stage of the labor. And also it is a very good tool for the healthcare providers to take the assess the patient's condition, record their observation, monitor the progress of the labor, and for the taking the action plan. So I think it is very good for us, as Dr. Farooq has told, that Dr. Arun Kumar is very, he has spoken all this labor care guide in the Bangladesh Society. So now, thank you very much for Sadia. You have invited us on behalf of the society. So we are very thankful to Professor Arun Kumar for being here. He will guide us about how to implement on this as a Society of Obstetrician and Gynecology of Pakistan, how we will implement, how we will give the training to our junior and senior staff, as Lubna is always working in this. So I am thankful to all of them, especially Professor Arun Kumar, who has given a time to SOGP. And I am thankful to past, both are the past presidents, Dr. Farooq and Lubna Hasan. Both are very, they are old SOGP, so they know well SOGP than me. And especially, I thank you both of them, and I thank you to Professor Sadia Sanpal, always with me and organize these wonderful webinars. At the end, I am thankful to Sami Pharmaceutical Company, who have always supporting the SOGP. So thank you, Sadia. Now you have to carry on. So
Thank
I
you, Professor
am very
Razia.
thankful to all of you. Now we will take how this labor care guide we will implement on the in our country, in our setup, on behalf of the society. Thank you,
Thank you.
Sadia.
Thank you, Professor Razia. So I will quickly introduce, although we were discussing earlier, Professor Arul Kumar needs no introduction. He is a world-renowned figure in the sphere of gynae all over the world. Uh, Sir Arul Kumar has been knighted, so that's why I'm calling him Sir. Apart from being a professor emeritus of obstetrics and gynecology and an ex-professor and head of obstetrics and gynecology from 2001 to 2013 at St. George's University of London. He is the foundation professor of Obs and Gynae at St. George's Medical School, University of Nicosia from 2014, visiting professor of Institute of Global Health Policy, Imperial College London from 2012. He's the past president of the FIGO, British Medical Association, and the Royal College of Obstetricians and Gynecologists. He was appointed Knight Bachelor by Her Majesty the Queen of UK in her birthday honours list in June 2009 in recognition of his services to medicine and healthcare, which are immense, as we all know. So he will be speaking to us shortly. I will also introduce our eminent panelists and co-chairs of this session, our past presidents of SOGP, Professor Zaman, who is principal and professor of obstetrics and gynecology at Latif Medical College, Lahore. He is FRCOG as well as all these additional FCPS degrees from Pakistan and Bangladesh, and he started his academic career at King Edward Medical College, Lahore, and retired as Principal Postgraduate Medical Institute, Lahore. He has also been the past president of SOGP, member of the Council of College of Physicians and Surgeons of Pakistan, member of the team that helped produce the first IVF baby in Pakistan, President Society of Obs and Gynae of Pakistan, and then also South Asian Federation of Obs and Gynae, SEFOG, member of the executive board of FIGO 2006 to 9, and chair audit and finance committee of FIGO as well. And we have Professor Lubna Hasan, who is also an ex-vice president of SEFOG, past president of SOGP, fellow of the Royal College of Obstetricians and Gynecologists of UK, founder, director of YDI, an NGO she founded herself, CEO of the Women's Hospital in Peshawar, KP, ex-chairperson, SEFOG Maternal and Neonatal Health Committee. So I will now request Professor Arulkumar to start his presentation. Sir, you can share your screen and we're ready for you. Professor Arulkumar?
Yeah.
Yes.
Thank you.
आ गया अरुण की तस्वीर आई थी फिर गायब हो अब उसकी
Oh, we are joined by Professor, your friend, Professor Rasheed.
Yes, thank you.
Yes. Welcome, Professor Rasheed. If you can hear us, we can see you.
Oh, thank
and
you.
hear you
Thank
as well.
It's always honor and pleasure to
Yes.
see the smiling face or Sadia and the great Sir
आवाज
Arul.
नहीं आ रही है डॉक्टर राशिद
Thank you very much, sir.
Yes, it's wonderful. So
वो शायद उधर
we
ही से
were
कुछ है
Yes,
नहीं आ रही है
patron to us. Always, he introduced me to Pakistan about 3 decades ago. So I'm most grateful to you for doing that and for the warm friendship. Then I have to thank Professor Razia Korejo, the president, Sadia Shan Paul for all the arrangements. And of course, I had to thank Farooq Zaman and Lubna Hasan professors to share this session and to give me this opportunity to share some information about my talk. So the topic is about migration from Partograph to labor care guide. And I will at the outset declare my interest. I have no conflicts of interest to declare. I've taken a lot of literature to produce this lecture, and these are purely my thoughts based on published literature. But obviously I had correspondence with Olufemi, who is called Femi in WHO, Metin, Mercedes from WHO, and Tina Lavender from University of Liverpool to put this lecture together. So my objective of the talk will be to why should we consider the issue of migration to labor care guide? Why can't we stick with the Partograph? Why should we do that? Secondly, to understand the historical aspects of the Partograph. How did we develop this WHO Partograph? And where did we go wrong? Thirdly, to look at recent labor progress curves, the recent research done by different people to see what might be the best way of identifying what's normal progress of labor. And finally, suggests the management of labor care guide in the future and draw some conclusions. So one of the main reasons we are looking at labor is because the cesarean section rates are going up. So this is a well-publicized slide. As you can see, in different countries, the cesarean sections are rising. And if you look at the world map, you can see, for example, if you take Pakistan, the section rate is low, but if you take the capital cities of Pakistan, like Lahore or Karachi, then it might be high. So there is within the city, there is a regional variation, but because of the rural nature of many of the countries, the country statistics might show a lower cesarean section rate. It is also influenced by other factors. If you look at these countries based on the Organization for Economic Cooperation, you see on the left of the scale, Turkey, which has about 53%, then Mexico, 48%, and so on. And on the right side, you find the Nordic countries, which has 15-20% section rate. And the UK comes from about 26%. Now, this is based partly because there is the more care is given by private obstetricians, there's a higher section rate because they can't be up the whole night. They don't need dependent care specialists or midwives to look after. Fear of litigation puts the section rate up. And thirdly, less counseling as to the risk of and benefits of cesarean section. Cesarean sections are lower where it is a nationalized health system. There are organized guidelines and organized proper training and so forth. So we are caught in the middle, and roughly globally, if you take the average section rate is about 27%. So which is, whether it is high or not is a major question. So to look at the 27% section rate, is it acceptable even globally? WHO did some study, and especially Annabella Petron did a number of studies on this and looked at what will be the optimal cesarean section rate to reduce the maternal mortality, which is the left side graph in per 100,000, and neonatal mortality, which is per 1,000. And as you could see, that when the sections are done, as we increase the section rate up to 10-15%, the section rate does not produce additional benefit from maternal mortality or neonatal mortality. So therefore, earlier, the WHO took a stand, 15% might be approximately average and not 26% as I showed you earlier on. But there are limitations in WHO analysis. Correlation doesn't mean causation, because in some countries, the area in which the population is living might be more urban with high section rate, whereas others might be more rural with lower section rate. And also the current data did not enable assessment of the benefit of higher cesarean section, which is more than 30%, because they stopped the analysis once they reached that horizontal plateau. So is mortality the only relevant outcome was the next question, because, well, we might be saving on the morbidity. Maybe there are less cases of hypoxic ischemic encephalopathy, and pediatric outcome might be better, and there might be better psychological or social well-being for the mother. So we can't really take the maternal mortality or neonatal mortality as the key factors, but we have to look into the other factors as well. So when the WHO was challenged at this stage, then they come out with another statement in 2015 saying that they do not promote any specific rate to be achieved at population level, and they should provide cesarean section to all women who need, rather than trying to achieve a specific rate. But they recommended maybe each country, each region should use Robson's classification to look at their own cesarean section rate and seeing why the section rates are high, where can we reduce the cesarean section rate. So WHO came off that 15% standard section rate in 2015. Now, Robson's classification is a very straightforward one. It is not based on indication. It is based on 5
मेरी
factors:
इधर पानी की बोतल है एक पड़ी हुई
onset of labor, gestational age, fetal presentation, and number of fetuses. So the straightforward: parity, monaliparous or multiparous, onset with a spontaneous induced or elective section, gestational age, whether it's over 37 or less than 37, fetal presentation, and number of fetuses. This is on a larger scale. And group 1, 2, and 5 are the predominant causes of the high section rate. Number 1 is nulliparous with single cephalic pregnancy over 37 weeks in spontaneous labor. So we are managing the spontaneous labor with Partograph. So what are we doing wrong is the question. Number 2, nulliparous with the induction of labor or elective section. So nulliparous contributes a lot. And the moment they contribute the section rate, they jump to number 5, because they are multiparous women with at least one previous cesarean scar, because they don't get a trial of vaginal delivery. They are done as an elective section. So 1, 2, and 5 contributes a maximum cesarean section in any country compared to nulliparous with breech or multiple pregnancy. They are a small proportion. Now, we might say it is a very simple thing, but there was a recent study in 2019 done in Africa called the ASOS study, African Surgical Outcome Study. They did a 7-day prospective analysis and found that the cesarean sections produce more maternal mortality. So this is the detail of the study. They studied 3,790 mothers in 22 African countries. And in 2016 and 17, the maternal mortality is 5.4 per thousand operations, compared to 0.1 per thousand in the UK, for example. So it's 50 times higher. But we must remember that maybe the complications might be higher in these countries, like preeclampsia, ruptured uterus, bleeding, and so on. But sub-analysis showed even intraoperative bleeding was a major factor, partly because the operators are not trained enough, and partly because there was no blood transfusion facilities available to give enough blood. So there are issues related to cesarean section in the middle and low income countries. So that brought to us the message that we shouldn't expose women to unjustifiable health risks, because our Hippocratic oath is primum non nocere, so we shouldn't do any harm, and we should do on beneficence. So these studies generally kicked up a little bit of a curiosity, and even in the United States, they started analyzing, and they started with a slogan, preventing the first cesarean delivery, because that gives rise to the problem. And if you look at the detailed analysis, you can say the maximum cesarean section is at the time of labor. If you say in labor, first stage arrest is 15 to 30%, and second stage arrest is 10 to 25%, failed induction is 10, and non-reassuring fetal heart rate 10. If you lump all them together, what happens in labor, that contributes to 50 to 80% of problems in labor, which give rise to cesarean section rate. So if you sub-analyze them according to Robson's classification, they fall into these three. That is nulliparous over 37 weeks in spontaneous labor, nulliparous with induced labor, or women who had one previous section. So these three groups, if you want to reduce that, we have to reduce the primary section rate. So we will go back in history to see why have we gone wrong. Well, we based our partograms on the Friedman's graph or Friedman's labor analysis scientifically. Very few people read the original paper. They all thought, well, he has described normal labor. This is actually the original paper. As you could see here, in the Friedman's paper, 68 had forceps, 1 had section, 1 had frank breech, 4 had pitocin, 15 had augmentation. So by any length of imagination, this was not a normal labor, but people jumped onto the idea this must be the right thing to do. And the second thing we mistook was actually the Friedman did not describe the slope of labor minimum dilatation as 1 centimeter per hour. He said in his original paper, the maximum slope is 1.1 centimeter per hour. But somehow or other it got mixed up, and people thought the women should dilate more than 1 centimeter per hour. So the slower dilatation might be even less, 0.3 or 0.4 centimeters per hour. So that was missed in the presentation. Now, Philpott, who worked in Zimbabwe, got involved in partographic study. Mainly, he wanted to prevent women getting fistulae because of prolonged labor. So he decided to construct an alert line and an acceptable action line based on servimetric progress. So although when he studied these African primigravid, they were dilating slowly, he says we tried to establish the rates of cervical dilatation of a normal African primigravid, So a similar pattern like Friedman can be described as a yardstick. This proved not to be the case. So their labor curve was slower, but nevertheless, because they didn't have concluding studies, he took Friedman's curve as 1 centimeter per hour and constructed a graph at 4 hours to the right. So his main aim was to separate efficiently the majority of normal patients from the abnormal patients so that they can be transferred in time. So he took 1 centimeter as the average or mean and took 4 hours to the right to intervene. But on the Western side, they took to the other extreme. They said if it is slower than 1 centimeter per hour, that's the maximum slow, if you remember, according to Friedman. If it is slower than that, they should have oxytocin. So as a result, Kirian O'Driscoll produces active management labor strategy, and 55% of nulliparate had oxytocin. So there was far in excess, and that came as a standard. And their Partograph lasts only for 12 hours. So WHO took this on as a challenge because they didn't know which one to recommend, whether Philpott's Partograph or the Dublin Partograph. So they convened a technical working group in 1987. And not only they wanted 4 chapters to be written about the management of labor, but they wanted to do a prospective wedge randomized study. And they selected Indonesia, Malaysia, and Thailand. And this is the WHO Partograph. As you can see, the alert and action line 4 hours to the right, the fetal parameters on the top, and the maternal parameters in the down. So they decided on the left of alert line, no action, right of the alert line, transfer to the peripheral unit. If it reaches the action line, review for augmentation. So you have to wait till it reaches the action line. The prolonged latent phase is just a review by medical staff, and we established at 8 hours. So the original Partograph from Philpott was taken as the basis, and the 3 of us, myself, Barbara Cost, who was the midwife who worked with Philpott, and Christopher Lennox from Papua New Guinea, we sat down for a week or 2 and produced this Partograph for the WHO. And we said 8 hours is latent phase, alert line is 1 centimeter per hour, 4 hours to the right is action line, and we'll see what happens. So we decided on the principles. The active phase of labor commences at 3 centimeters. Latent phase should not be longer than 8 hours. Active phase should be 1 centimeter per hour, and lag time 4 hours to the right should be given. And the study was done in Indonesia. Then WHO appointed their advisors to each of the country. I looked after Indonesia at Budu Kemuliaan and Tangerang. Thailand was Ken Stewart, and Malaysia was Christopher Lennox, and overall by Barbara. And this was the publication. And as you could see, we clearly showed that the rate of augmentation can be reduced if you use the Partograph, because otherwise they were using oxytocin just because their contractions were 2 or 3 in 10 minutes. The emergency section rate could be reduced. That was also shown. And also the stillbirth was marginally reduced. So these are the 3 factors we looked at. The number of augmentation fell from 20 to 9%, emergency section 9 to 8%, and stillbirth 0.5 to 0.3. And these are 35,000 women who studied. Now the Cochrane doesn't include this study because it was a wedge randomized study, and they thought it was not properly done. They wanted to go back on the results, but the results are not made available by the WHO. So that was the norm which was established by the WHO. But then because there were rising cesarean section rate, alarm bell rang, people wanted to look at it. And Zhang in 2002 did a retrospective analysis of 1,329 nulliparous women. And he showed that compared to Friedman's curve, where the active phase starts at 3 centimeters, as you could see, according to him, the active phase starts around about 5 centimeters. Then only it's 1 centimeter per hour. But the numbers studied were only 1,300. So he was very keen to study nulliparous and multiparous. So he produced this figure in 2010 with 62,000 women. So this is nulliparous women, this is multiparous women. And as you could see, only after 5 centimeters, there is almost a good dilatation of 1 centimeter per hour. Now, if you put it in numerical value, this is what you will see. The median dilatation, it takes 1.8 hours for 3 to 4, But 95th centile, 95% of the women, if they are left alone, they might take even 8 hours. 4 to 5, they'll take 6 hours. 5 to 6, they will take 3 hours. But after 5 to 6, they were dilating at 1 centimeter per hour or less than that. So if I was to construct a partogram now, I will start the active phase only at 5 to 6 centimeters. And then I would put the action line 3 hours to the right. So that is what has been translated to the labor care guide. The American college immediately jumped the gun, and they said after these studies from Zhang, said that they will extend the latent phase to 20 hours in nulliparous, 14 in multiparous, and 6 centimeters should be the start of the action line. And they should give at least 6 hours of oxytocin to see whether they would progress further. And we had originally done a study from Singapore in 1987 that if you are starting augmentation for failure to progress, you must give 6 to 8 hours with good contraction to achieve the maximum vaginal delivery rate. So which was coinciding, this study was coinciding with the recommendation of the American College. Now, WHO was not satisfied with that all because there was a lot of protest about how do we respect mothers and so on. So they said they must do some original research about the progress of labor to bring the knowledge gap. They also should do systematic reviews of all the labor curves published to date. They will do qualitative studies on what the woman wants and expectations of the mother during birth, and the implementation tools. How would we revise the Partograph? And how would we implement if we come with a labor care guide? So there are 4 components: research, knowledge gap, synthesis, and so forth. So I'm going to touch one example of research, knowledge gap, and synthesis, and so forth. So this is a BOLD project, which is actually better outcome in labor. And this is a protocol which was published in 2015. And this is how the labor curves will look like. Say, this is 10,000 women from Nigeria and Uganda, started in 2016. They let them progress in labor as the black lines appear. They did not intervene because the labor was slow by rupturing the membranes or giving oxytocin. And they managed to plot 10,000. These are nulliparous women, as you could see. And if you construct a line, the action line should start at 5 centimeters. Then after 5 centimeters, it is going at a straight line. So they decided they should convey that primary gravity, we shouldn't intervene unless they are 5 centimeters dilated. Now, this is multiparous women, again, from the BOLD study of 10,000 women. And the black line shows there are some of them who dilate and deliver as expected. There are some of them go for 10, 15, 18, 20 hours, so some of them. So you might wonder what happened to those who went into longer labor. Did they have a poor maternal or fetal outcome? The answer is no. So let us look at this dilatation pattern on the existing partogram. This is the existing partogram. And I'm going to extract the labor curve only to be shown, and then plot the labor progress of all these women, those who had good outcome, both maternal and fetal outcome. So as you could see, even if the woman delivered 15 hours, 18 hours, 20 hours after the labor started, they had good outcome. Now I'm going to plot those who had poor outcome to see whether all those with poor outcome to the mother and baby, were they dilating very slowly or whether they are dilating very quickly or in between. So the red lines will appear in my next line, which will show that there are equal number or more of poor outcome in the fetus and the mother, as you could see. The red line shows. So even if they had a shorter labor, they had poorer outcomes. So in other words, the cervical dilatation pattern did not predict the poor outcome in the mother or baby. So we are so obsessed all this time with the Partograph, we must not let them go into labor. Well, this has been coming on from previous, they say not to let the sun set twice on the laboring woman. So that's the same similar principle because they are worried about fistula. So this particular study, the BOLD study, was published in the British Journal. And it says the conclusion, our findings suggest that the labor curve is very variable and assessment of a dilatation over time is a poor predictor of severe adverse outcome. So the validity of a paragraph alert line based on 1 centimeter per hour should be reevaluated. So that was the conclusion of the BOLD study. Now, if you put that all that graphs into numerical values, I'm taking nulliparous women here. If you watch this carefully, from 2 to 3 centimeters, on an average, the median, they took 8 hours to dilate. 3 to 4 centimeters, they took 2 to 3 hours. 4 to 5, just over an hour. 5 to 6, only they start at 1 centimeter. So in other words, action line should start at 5 centimeter. This is based on not only the BOLD study by Oladapo, but also the Zhangs analysis, Suzuki's sheet. So this is a systematic review of existing Partograph, which all suggest that 5 centimeters should be taken, because after that, they tend to dilate at 1 centimeter per hour or less. So that is very conclusive, not only from the BOLD study of 10,000 women, but also from the systematic review of all the Partograms available. Now, multigraph, it is the same story, that 3 to 4 centimeters, they take about 3 hours, 4 to 5, just over an hour, after 5, 1 centimeter or less. So in other words, 1 hour or less to dilate. So in other words, we can, for nullipare and multipare, we can conclude that in future, the action line should be at 5 centimeters and not lower than that, and we shouldn't intervene because we might run into problem. And just because the labor is going to be long, even in the active phase, it is not going to cause poor outcome to the mother or baby, provided we support them with hydration, nutrition, monitor the mother, monitor the baby. It's not going to go wrong. Now, I mentioned WHO wanted to do a qualitative study. And what did the woman want? They wanted a normal birth without intervention. That was number one. Number two, they wanted a healthy mother and baby. Number three, support from a birth companion, because that is known from the Cochrane data analysis itself that it gives a better outcome. Desire to be uncontrolled. So they will say, should I labor for another 3 hours? That decision should be made to the mother, given to the mother, and not forced on them, provided the mother and babies are in good health. And finally, sensitive, caring, kind, respectful staff. So how do we put this qualitative feeling of the mother and what they want with the scientific labor craft, the Partograph for progress labor studies together? So they came out with 5 elements. Respectful care is number one, how to support, how to give support to the mother, communication, and how do we communicate about what is happening. So you need more staff to do that. Labor companion. Labor companion doesn't mean the husband or the mother or sister standing by. They must perform some duties. And number one is he or she should be advocate of the patient, should be the advocate of the patient. So if the mother is saying, I'm feeling hungry, if I'm feeling thirsty, they should be able to get them the food and the water and so on, rub their back, reassure them, call the attendant, the midwife or the doctor if the review has not been done for some time or if she bleeds or something. So the labor companion has some task to do, not just standing there, and they should be educated before the mother goes into labor. Essential physical resources, including the facilities for toiletry and so on, should be, because it was known the poor outcome, especially with group-based streptococcus sepsis, was due to poor hygiene. And to avoid overcrowding, how can we manage and so forth. So this was all put together. So we look at what does Cochrane say about all this. So Cochrane Analysis was published by Tina Lavender in 2018. So this is interesting. They looked at existing studies. They found 11 studies, 3 compared Partograph with no Partograph, and 8 compared different designs of Partograph. So in the 3 studies comparing Partograph with no Partograph, there was no evidence that standard use of Partograph was favorable to no Partograph. So it blows out everything, saying whether you use the Partograph or not, it doesn't make any difference. Exploring different Partograph designs failed to provide any particular evidence of advantage. And perhaps the most convincing study was which compared one with and without latent phase on the chart, and that without the latent phase had less augmentation. So this study demonstrated that cesarean section and augmentation rates were higher when Partograph, which included latent phase. So WHO pulled the latent phase out. So in other words, Cochrane in 2018 also came to the conclusion that they are not sure whether using a Partograph helps, that means we should do something different. So all these evidence I have suggested, plus the Cochrane suggests we have moved from one to the other. So should we move to Zhangs Paragraph then? Well, Zhang also combined with the Norwegian physicians and obstetricians did a randomized control study, which was published in the Lancet in 2019. And this is their conclusion. We did not find any significant difference in the frequency of intrapartum cesarean section between obstetric units adhering to WHO Partograph or the Zhangs guideline. Overall, there was a decrease in section in both sides, both arms. This might be because they were observing the labor closely. So their conclusion was the Partograph, whether it is Zhang or WHO, did not contribute significantly to any change. You can use either of those, but we have shown that Partograph use or no Partograph use on the Cochrane didn't show any change. So where do we stand? We are at a loss now. So that is why WHO decided to introduce intrapartum care for positive childbirth experience. So this is the crucial, there are a number of pages on this document, which you can say intrapartum care for positive childbirth experience at WHO. But I just want to show only two things. Number one, definitions of the latent and active phase of labor. So they agreed that based on all the analysis they have made, 5 centimeters should be made for first and subsequent labor. And the active first stage is a period characterized by regular painful contraction, substantial degree of cervical effacement and dilatation from 5 centimeter to full dilatation. And duration of the first stage, again, they said because there's a wide variation, you can give up to 12 hours in the first labor. So 5 centimeters to 10 centimeter, normally we would give 5 or 6 hours, but they said, no, give 12 hours based on the dilatation curves observed. And in a multiparous case, give up to 10 hours. So that is their recommendation from that curve. And what one should not do is to intervene because she's slowly dilating 1 centimeter per hour, less than 1 centimeter per hour. Minimum cervical dilatation, 1 centimeter per hour throughout active phase is unrealistically fast. So in other words, they're emphasizing that we shouldn't really intervene, we should give more time. So not only not to intervene before 5 centimeters, but even later to give 6, 7, 8 hours. So if she's 5 centimeters, give about 8 hours, 6 centimeters, give about 7 hours, and so on. So much longer period. So this was combined to form the labor care guide, in addition to all the other components from qualitative studies, which are respected labor and childbirth care, emotional support, effective communication, pain relief, regular labor monitoring, oral fluid and food intake, mobility in labor and birth, pre-established referral pain pathway, continuity of care, and so on. So all this has to be combined in the labor care guide. So that is labor care guide. And I'm going to dissect that into small portion so that we understand what it is. The most important part in this labor care guide is to pick up if something is going to go wrong. So these are called the alert features for each of the parameters we are looking at. Whether it's a qualitative care or a quantitative care, what are the alert features? And the alert feature key is given at the bottom, but I'll just explain to you by taking panel by panel. So the first panel, section 1, has identification and admission. So you can have the name, parity, labor onset, and so on. The second panel is about supportive care. That is very important. Supportive care has companion, pain relief, oral fluid, and posture. If the companion is N, not available, then it becomes an alert. So you put N and put a circle around it or put it in red. If the companion is there, she is told what to do, to act as an advocate, give her some fluids, give her some help with the posture, and also reassurance and so forth. So what are the alerts for these parameters is given at the bottom, and we can have a look at it. The third is about care of the baby, the baseline fetal heart rate. So in the past, we just plotted the heart rate, but the alert feature is if it is more than 110 or less than 110 or more than 160, it's an alert feature. And they also included that by auscultation, you can do late deceleration. So if it came out late, you put L there, every half an hour, you are supposed to auscultate. If it is L, then it comes under red. Amniotic fluid, if it is thick meconium, 3+, it's an alert feature. Or blood stain, it's an alert feature. You will mark. If it is clear, you put C. There's no need to put a round or red. But if it is blood stain B, then you put a red or put a circle around to alert. Fetal position, OP or OT, because their labor is going to be longer, they might go into difficulties. So you put an alert, caput 3+ or molding 3+, 2+ not, but 3+, yes. Woman, pulse rate less than 60, it's dangerous. There might be something going wrong, or more than 120, it's an alert feature. So these numbers are plotted where they are circled around so that they know it's an alert feature. Systolic blood pressure less than 80 or more than 140, diastolic more than 90, and temperature less than 35 or 37, and urine, protein, acetone. So these alert features plotted in this graph, if it is diastolic pressure 80, you'll put 80 here, but there's no need to take any action. But if you have an alert feature, especially if you have two alert features, then a senior person should be called. And depending on how variable, so how varied it is, you have to call a senior person to come in. Now, in order to help the late deceleration to be detected, people are changing these Dopplers, which are digital display, which with one switch, you can put it into a graphic display and you can identify small late decelerations as well. So that's a possibility in the future. The section 5 is with contraction frequency. You will put number of contractions and the duration. So if it is 3, 4, 5, then you can put it that's normal. If it is less than 2, you will alert as less than 2. And if the duration is more than 60, or if the frequency is more than 5, then it's an alert feature. Similarly, cervical dilatation, this is the major variable from what we are so used to. So cervical dilatation plotting or changing starts at 5. So this is not a graph. This is 5 centimeters. And to move to 6 centimeters, they are giving at least 6 hours. So if it is more than 6 hours, she has not moved, that is of a concern. 6 centimeter, they give 5 hours, 7, 3 hours to move to the next segment, and so on and so forth. So if you plot a labor curve here, and it might go somewhat like that, that is not abnormal, because not 1 centimeter, but you can give more time because it has been shown earlier that it doesn't matter. Descent, it doesn't matter because some mothers, especially multipare, it can be station -3, and within a few push, it'll be +1. So they decided not to put any alert parameters. Section 6 is about medication, especially oxytocin and any other medicine and IV fluids. And assessment of the mother and the baby has to be written, and the plan and the shared decision making with the mother or the partner should be there. And section 8 is the birth outcome, which is actually about mode of birth, blood loss, neonatal status, ABGAR scores, and so on. And these are the alert parameters to remind everybody at the bottom. For example, yes is Y, D is decline, U is unknown, and so on, protein, acetone, occiput transverse posterior, they will put OP and so forth. Now, this is all has been studied and published in an article in 2020, July, about the initial experience, the usability, acceptability, and feasibility of the WHO Organized Labor Care Guide. And they have produced a manual, which is the WHO Labor Care Guide Users Manual, which gives how to individually look at each parameter and plot it. The reason they have come out with this urgently is because of this reason. I will read it out. More than 1/3 of maternal deaths, half stillbirths, and quarter of neonatal deaths results from complication during labor and childbirth. The majority of these occur in low-resource settings and largely preventable through timely intervention. Monitoring of labor and childbirth and early identification and treatment of complications are critical for preventing adverse birth outcomes. Improving the quality of care at the time of birth has been identified as the most impactful strategy for reducing stillbirths and maternal and newborn deaths compared to antenatal and postnatal care strategies. So this is actually becomes quite an important area for us to grapple with in country-wise. So my conclusion is actually maybe in Pakistan, you should get together, get the labor care guide, and create some pilot studies to see how easily it can be applicable, because If you have less staff and huge number of patients, it may not be possible. So you have to find the feasibility of using the labor care guide in your own settings. That must be the first thing. The second thing, Pakistan can lead the world by organizing randomized control trials of comparing labor care guide with WHO Partograph. The labor care guide, as I mentioned, has additional component about the qualitative aspect as well, about the companion, about giving fluids, about posture, about analgesics, and so on. And I've given the website there at the bottom, but there's no need. You can just type WHO labor care guide in the Google and you'll get the document, and you can pass the document around and maybe start implementing it as a prospective, and then try and do a randomized control study. Maybe one hospital observing labor care guide, the other not, using the original WHO Partograph, or in the same hospital, there are 2 labor wards, you can randomize them to do 2 different things. So I would stop there, and I'm happy to answer any questions. Thank you very much indeed.
Thank you, Professor Arulkumar, and that was an excellent presentation and a reminder that evidence-based practice can improve outcomes both for the mother and the
जी मैं
baby.
नहीं पीऊंगी कुछ नहीं मुझे चाय दो
So
बस
I will just to share with you that only last year before COVID started, we had an emergency obstetrics and newborn care course in Karachi, in which this was organized by SOGP, and we had senior professors from all over Pakistan, and we discussed the WHO Partograph and the recent recommendations of WHO, which you just shared, and the ACOG, which is recommending starting it at 6 centimeters and WHO at 5 centimeters. And we came to a consensus, this is professors from all over Pakistan, that 5 centimeters sounded really most appropriate to us. And that was the starting point. And then COVID happened. So I think your suggestion that we do randomized control trials is an excellent one. So I will open the floor for Professor Farooq and Professor Lubna Hasan to give their comments, and then maybe we can have some questions for you. Professor Farooq.
First of all, Professor Arulkumaran, excellent as always, and extremely lucid. You made things, they couldn't be made clearer than this. And you have put everything into perspective. The amazing thing which has come out is that labor is such a common procedure or common occurrence. And day in, day out, this is the most common happening in obstetrics. And Friedman, well, he published his study more than almost 70 years ago. And we still are not sure how labor progresses and how to manage that, and whether to intervene or not to intervene. And this is quite amazing. But I think there has been this paradigm shift in that instead of calling it a partogram, now we are calling it labor care guide. I think this is an important step which has happened over these years, because partograms were still open to question. This document, or this one page, incorporates a kind of comprehensive labor care, and also monitors the progress of labor, incorporating the current viewpoint about the rate of dilatation of the cervix, as you showed in those dynamic graphs in which the labors of primigravida and multigravida were shown separately, and then also of those women in whom the outcome was not as was expected, or something went wrong with that. So therefore, I think that this is something which is practical, and I must commend you for the practical suggestion that you made, that it may not be sometimes possible in some areas or in those units where there's large influx of patients and there may not be enough staff. Still, I think that initiating this activity to monitor labors, I think that it will go a long way in preventing or in reducing maternal mortality and achieving that target of achievement of minimizing maternal deaths and also improving perinatal outcome. Once again, I would like to thank you profusely for this excellent talk. Thank you very much.
Thank you.
Yes, Professor Lubna.
Thank you, Sadia. Thank you very much for inviting me to be part of this. Thank you, Arul. It's so wonderful always to see you and to hear you speak, because when something comes out of the mouth of somebody as illustrious as you, automatically it makes our job much easier when we are trying to implement something. So thank you very much. In fact, today I was in a training session. We've started the Robson's training with WHO and the government, the health department. And we are actually training senior clinicians throughout Pakistan since the last 2 years. So today I did one in Peshawar. And I was just so happy that a few hours later, I was going to come and listen to this, because all we've been listening to is the Partograph, Driscoll's, the active management of labor. And it is just so ironic that from the very same place we now have the Robsons, where we had the active management of labor. Like we just we seem to have lost patients, like what Dr. Farooq was saying, but we seem to have just lost patience with our patients. We want labor to hurry up. The obstetrician gets distressed, the families get distressed, the woman gets distressed. They want to do it quickly, just like everything else. And that is a mindset that we have to change. Today we were talking about having the companion, and there's always a negative to that. And all the senior clinicians in the public sector and even in their private hospitals, they said, no, but the mothers come and they interfere and say, she's in a lot of pain, please hurry up and do a cesarean. We're willing to pay, hurry up and do a cesarean. So, it's going to take a lot of work to change that mindset. This waiting for them to dilate, failure to progress in primaries is one of the biggest indications, and failure to progress because they start active labor, with the first pain or 2 centimeters. We were actually haggling to find a consensus on the definition of spontaneous labor. Every clinician had a different definition. So, but I think so this, if it's come from the WHO and it has proponents like yourself, I think it will slow things down. It will make people, step back and watch, because you'll be surprised in the public sector hospitals in Pakistan, our cesarean section rate, the range is between 15 and 48%. 48% in a public sector hospital, and many of them in group 1. Hardly any in group 2. They're not inducing, they're not doing elective, because they say they come complicated in labor, but complicated, and then we have to do section. So we have our own dynamics, and I think Robson will really help us study it. And so thank you very much. And it's really been a pleasure to meet you and to listen to you.
Thank you.
Okay, so we have Professor Razia and Professor Rasheed and Dr. Azra, and I'm not sure if Dr. Shaida is there, but if any of you have any comments or questions, please go ahead. Dr. Razia, your mic is mute. Dr. Razia, your mic is mute, so unmute your mic.
Dabao, Razia?
Okay.
She's with us again.
Mhm. Dr. Rasheed, Professor Rasheed, would you like to speak first, please? Your mic is mute. You have to unmute your mic, sir. Yeah.
Acha, Sadia, can you hear me now?
Yes, I
Hello?
can. Yes, Dr. Razia, we can hear you now.
Okay, okay,
Okay.
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 So
So,
first, thank you, Sadia. So first of all, I would like to thank you, Professor Arun Kumar, and congratulate him for very excellent nice presentation on new labor care guide. I said it is a next generation partograph. So we have to implement in our setup. You know, the partograph, old partograph, WHO partograph, we did a lot of work on that. So now we add on behalf of SOGP, we have to work on this and we have to conduct the workshops to see how to implement this new labor care guide in our own setup. And to, as Lubna said, the cesarean section rate is going on and high and high, even in public sector hospitals, because of the patients usually in the tertiary care hospitals, patients usually come in the emergency. So it is very difficult to use this lengthy partograph. So, okay, we will try it on behalf of SOGP, you, me, and all these. We will conduct the workshops as we did the workshops on emergency obstetric care. So we will do on this workshops on the new labor care guide, and we will implement on this. So thank you so much for organizing. I will must thank you all of you to organizing this seminar webinar. Very important topic, new labor care guide. So we will hope we will do something for the future and for the best. So we have our own idea, SOGP's own idea is to reduce the maternal and mortality, morbidity, and perinatal morbidity. So we are trying so much for the SOGP is doing all the workshops and this to improve the knowledge and the skills of the healthcare providers for the decades. As we all know, that we are conducting so many things, workshops on this to reduce the maternal mortality. But as we are doing something going, so inshallah we will get the some improvement. So this is very good. So I much thankful to Lubna, Hasan and Dr. Farooq for being here and their comments. And I am thankful to Professor Arun Kumar for being here, giving us giving us a very good knowledge and spending us his valuable time for us. So I am thank you for all of them, and especially thank you for you to organizing this. You are always helpful to SOGP. You are one of the SOGP. At the end, I am most thankful to Sami Pharmaceutical Company for organizing this seminar, because they are, without their support, we can't arrange this. So I am thankful to all of these. All the boys are sitting here with me. They are doing wonderful job. So thank you so much, Sami. And now, thank you everyone. And
thank
I
you.
hope every one of our SOGP member and all of the healthcare providers who are today with us, who had listened this Dr. Arun's presentation and talk, will get benefit from this. So thank you so
Thank you.
much.
Thank you, Dr. Razia. And I would really, we are really honored that we have Professor Rashid Latif, who has joined us. I mean, he and one of his best buddies presented today. So it's an not old, young boys club of doers of this, this region and UK as well. So, sir, I know you've devoted your whole life to this profession. Would you like to say a few comments about this?
Thank you, Sadia. First of all, I also join my colleagues in thanking Sir Arulkumaran for giving us this much time and his valuable time. He's a very busy man, but he spares his time always for us. And his contribution is immense in promoting Pakistan and Pakistan gynecologists. Perhaps amongst those who are online and listening, I am the oldest person. And I remember when I was preparing for MRCOG, I read Munroker's Operative Obstetrics, many times in which all destructive operations or procedures were described. But that is history. No more we would like to see those destructive operations or operative history as Monroe described. But from those days to date, we have come long way in management of labor. But perhaps still there is so much more to learn. And because these days in our country, basically, whether it is induction of labor or natural labor, it starts in the morning. By the evening, everybody is fed up. As it was, Lubna said, that mother is impatient, so is obstetrician, so all the caring people. And that's how the cesarean section rate goes up. With this labor care guide, we must thank those who have designed it. Arul is part of that, and he gets the special credit for that. That with this care guide, I'm sure there will be better care, because this is a very comprehensive chart. It is not like Partograph, which was missing so many important components of labor care, and they have introduced those. Um, um, Mother's condition, and so is fetus, so is the progress, which has been rightly from 1 centimeter right from the beginning. It has taken from 5 centimeter, we calculate that. Because that first latent phase was the important phase which made us do unnecessary cesarean sections. So thank you, Razia, that organizing workshops, and Lubna for organizing from Peshawar to Karachi. If all of you get together and conduct various workshops, introduce patience in all sections. In Pakistan, the companion is really working to push the labor. Companion is pushing the doctor and nurses, do something, pain. So here we have to train our companions as well. But all of us, if get it together, I'm sure the optimum cesarean section rate, which perhaps we have not come up to, whether it is 15% or more or anything, and we'll achieve that. Unnecessary cesarean sections will be avoided, and we'll have happier patients and relatives. And of course, with that, morbidity, mortality of all kinds will be reduced. Arul, I can't thank you enough for everything you've done for us. And it's always a pleasure to listen to you. And I can't thank, my vocabulary is very limited. So I can't find appropriate words to thank you. But I can tell you that only yesterday I was discussing with Farah that in our labor room, put this chart. If the chart is not complete, don't see the patient. Just pass by it and let the junior doctors or responsible persons complete the chart, because we are not in the habit of documenting everything. So this chart demands documentation. So all of us, if we have this attitude, that chart must be complete, only then you will see the patient. So it will force our juniors to do the needful, make full use of this labor care guide. Thank you, Sadia.
Thank you, sir.
Mashallah. Every time I look at you, you look younger.
Thank you, sir,
Thank you,
for being so patient. So, Professor Arul, I've been looking at the at the question box as well. While you've been speaking, we have an audience of we had an audience of nearly 100 gynecologists. And we are live on Facebook as well on the SOGP page, and this is recorded, and it will be on our SOGP page. So those of us who have missed it or want to hear you again can do that very easily. And I will request you to visit our page as well, if you're on Facebook. The thing is, you spoke so clearly that I think we've all understood. You made every point so clear that there are very few questions. Like most of them are just praising your lecture. You've driven the point home very well. Um, so thank you so much. And I know you have probably got another commitment after this. You took your precious time out for us. But would you like to say something in the end before we conclude?
Thank you very much. If I can just answer a couple of questions. Very
Yeah,
quickly.
sure.
One, it says, does the same rule apply to extremes of age like teenage pregnancy? Well, there is no research done specifically for teenage pregnancy, so you have to really judge on an individualistic basis. So when we recommend as care guidelines or labor care guide, it is to what we call it Mrs. Average, not for the extreme, very young girl or very old person. So you have to use your judgment, but the general principles will apply. So you can use the same principle, but not to leave too long. The second is actually worried most of the obstetric practice has inclined towards private care, and that's the top reason for increased cesarean section. Well, that is also one of the issues, as Professor Rasheed, Latif Khan, and Lubna has suggested, that they all urge everybody is in a hurry. So that is something which I fully agree with Professor Rasheed and Lubna, that patient education is one, but also the mother's education or mother-in-law education. So the companions who are going to stay there, they should attend some antenatal classes or something to explain what is their responsibility and not to hurry labor. How can we introduce a labor care guide in these setups? Well, I think the Society of Obstetricians and Gynecologists of Pakistan can distribute the labor care guide as published by WHO and then conduct workshops. And by that, you should be able to introduce it. Patient
Yes.
education about changing. Yeah, so I fully agree according to the question. How much time should be given to the latent phase? Then according to the new guidelines, if we consider the active phase, 5 centimeters, yes. According to the WHO, there's no prescribed time, but the American guidelines, as I showed you, this says a primary gravid up to 18 to 24 hours, up to 12 hours. So as long as they are not in distress, give them the maximum time, hydrate them, give them reassurance, and you can wait. And that is something I mentioned. It'll be good to do a prospective study to see how much it takes for some of the women to dilate. How can we exactly start? So there are some questions for the society, how they're all anxious to start it, but how do we do that? I need to ask you, we quote and implement in our MRCOG prep, we follow RCOG guidelines. If it changes their perspective? Well, the labor care guide was published only latter part of last year. So it's going to take some time. Although the labor care guide preparation was going on, the usability, feasibility paper was published only last year. So I think it's going to take time for the RCOG and other colleges to recommend. But as I showed you in one of the slides, the ACOG has partly endorsed about the latent phase and the active phase. But I think we should not really think for ACOG or the RCOG to introduce. We should think the Obstetrics and Gynecological Society of Pakistan to introduce. So why can't we be the first? We don't have to be waiting till the RCOG or the ACOG does it. We should do the first because you are backed by a big body like the WHO. So I think I would encourage you to start the material of what the RCOG or the ACOG does. Thank you. That's all the questions, Sadia, that in a brief, nutshell.
Yeah, I think you've answered them very effectively. And I really like your suggestion about printing the labor ward guide. And we're going to have successive EMONC trainings in the next month or so. And we can easily do that. We can have this printed and that one-page partogram, the updated one, the WHO. And it should be easily implementable. I really think so. It is the attitude and behavior of the patients as well as the doctors. That is the real problem, and rather than the document itself. I think
Yeah,
that is a huge task.
one suggestion I might say is actually for the SOGP to communicate with CRO, the Southeast Asian Region WHO office, because they will be able to help you in providing enough material and also support and so on. So I think they are very keen.
Okay.
I
Because
think we are with EMRO. I'm sorry,
Yeah,
Sadi,
we
I
are
think we are
with,
with
yes,
EMRO and
we are with EMRO now, Pakistan. Yeah.
sorry
We,
about that.
but we will
but
contact EMRO,
we
yes.
can do it through EMRO. I've worked for them, and I
Yes.
think we can do
I think
something.
you should contact the MRO and see
Absolutely.
how much they can support your
Yeah.
endeavors to introduce the labor care guide.
And the country office is very keen, actually. I think
Yeah.
we can easily get them to collaborate with us.
Yeah, no, that'll be a good idea.
Yeah. Yeah. So that's our next step, and we will keep you in the loop. Thank you so much.
Thank you very much. Thank you,
We'll come
everybody.
and do the launch.
Thank you
I
all.
don't know if
Yes,
any of
Professor.
the other panelists have anything to say, but we've done very good with time, actually. We're only 10 minutes over time from what we planned. So this is an important topic. If people have time, most welcome. I'm worried about Professor Arulkumar, though, with his commitments.
No, I'm okay. If people want to ask questions, then I'm happy to.
Okay. So can I ask you a question?
Yeah.
A few, some years back, I came across the paperless partogram, which was like you don't plot a partogram. I don't know if you're familiar with the concept. It came from Bangladesh. And the fact that people hardly fill this document, it's a beautiful graph, but most of the time it's filled, even in UK, when I was working there, it was filled retrospectively after the woman had delivered. It would be plotted, and this is the same in Pakistan when it's plotted, beautiful graphs made after everything's over. So the paperless partogram concept was that, you have an estimated time of delivery and actual time of delivery. So just like we have those action lines. And so when a woman is, say, 4 centimeters, so 10 hours from that, you write in the chart that, okay, this is the time that she should have delivered by then. And if it's not happening, and if she's not dilating 1 centimeter per hour, you should be thinking, if you're not in a secondary care center, should be thinking about referral. So it's just getting the staff to think, because this is something they would do, but not plot the partogram. And I find that when we are managing patients, we do a mental maths. Okay, so she's 5 centimeters or 6 centimeters now. She should be delivered by this and this time. And if it's not happening, then something's wrong. So I don't know. What do you think about that?
No, there's, as doctors, midwives, nurses, and so on, it's a difficult concept to capture, saying going retrospectively, because the idea of labor care guide or partogram is actually to prospectively identify that things are going to go wrong and therefore to take action early. So the original WHO partogram was based on that principle, and Philpott introduced that 4 hours to the right guideline to transfer cases who might be neglected and left in hospitals, who might end up in vaginal fistulas and so forth. So they came to the hospital 4 hours after the right of when they cut the action line, and they got ARM and oxytocin. But if you're going to do retrospectively, you wouldn't know who would have cut the line, who would not have cut the line, and so on. Prospectively, it's easier to identify. So I think the concept is more difficult and as human beings working in different grades, a visual aid is usually more helpful.
Yes.
Rather than, because if I have, so I when I do the ward rounds, I look at the notes, I look at everything, I look at the partograph, I look at, and after discussing with the staff what is happening, what is going to happen, what might be the problems, then only I walk into the room to discuss with the woman and so on. So I think
Yeah.
documentation is, I think documentation helps a lot in medicine.
Absolutely, absolutely. So I'm not. This is just something that I came across, and in real life, just pointing out that this is what happens in real life. That very few centers actually fill that partogram. But anyway, we must pledge that we will start doing it properly, and we will do a randomized control trial in Pakistan, starting with all the lovely people we have here on this forum. And I will request Professor Farooq to conclude this meeting if he would. His mic is mute though, so I don't know if he's there.
One question about the latent phase, I would ask them to look at the lecture because the ACOG defines definitive periods for the latent phase. And the WHO labor care guide does not provide a conclusive answer, but they want a definitive answer, then it's about 18 to 24 hours. But I think the basic principle is to support the women till they go into the active phase. Sorry, Farooq is on the mute, I think.
Yeah, I think he's mute. So thank you so much. Thank you for taking time out, Professor Arulkumar. And I'm sure we will get more questions on the Facebook page. People often write that. And if we can answer it, yes, otherwise we may request you to answer those queries as well. And we will keep bothering you.
Okay.
Thank you so much. Thank you so
Thank
much.
you very much for spending your afternoon or evening with me. Thank you.
Evening. It was lovely. We're honored. And thank you, Professor Rasheed, Professor Razia Korejo, Professor Lubna, and all the others, Dr. Azra, Dr. Lima, all those who joined us. Thank you so much. Khuda Hafiz and goodbye.
Thank you.
Bye.
Thank you, everyone. Allah Hafiz.
Thank
Thank
you.
you.
Khuda Hafiz.
Bye.
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 बस मैंने तो पहले ही कर दिया था।
नजूर तो नजर आ रही हो, पहले कर दिया है। जाएं अब।